A row, a ruction, a fracas and a fray, a rough and tumble free-for-all, a broiler brawl, a Malay, a ruckus to be reckoned with if anyone wants to dare. We're taking the road to the Don or I'm down to the Donnybrook Affair. I will go, I will meet you there, I will spend a week or two with you at Donnybrook Fair.
Welcome to our fourth case, which is like the GYN results podcast. Special thank you to our panelists and participants and everybody here. Before we get started, I'd like to remind our attendees of a few things. Everyone will be muted with your webcam off, except for us and the panelists. If you want to communicate with us in real time, please use the chat box function, and we invite you to kind of share your thoughts and questions to help guide discussion. So I'll be monitoring that. We'll also be addressing everyone by first name to kind of keep this, collaborative and informal and fun. And if you haven't done so already, we do have a brief survey for you guys to fill out to let us know what you most benefit from as part of C3RO. So I'll post the link in the chat box as well. And then also stay tuned for some gift card giveaways a little bit later on and information regarding our next case. And if you have any additional questions, feel free to email us at support@econtour.org. So without further ado, we'll begin, and I'll quickly just have our panelists introduce themselves. So I'll hand it off to you, Simon.
Hi everyone. Yeah, my name's Simon Duke. I'm a medical doctor, so clinical oncologist from Cambridge in the UK in England. I treat gynae cancers there and largely radiotherapy, but I do give some chemo as well, and that includes a brachytherapy practice. I've just had 1 year as a consultant stroke attending, so I'm fairly new. But my PhD was in contouring and quality assurance and education of gynae, so cervical cancer contours with the Embrace Research Group. So contouring was my life for 3 years. But now I'm glad to say I've got other interests.
Yes, hi, I'm Emma Fields, and I'm a radiation oncologist. I am in Richmond at Virginia Commonwealth University, and I also mainly treat GYN. I also treat some GI, have a really busy brachy practice. Just moved over into a new center with lots of new fun equipment, so learning that as we go. And I'm also the program director and really involved in education. Thanks for having me.
Hi, I'm Sushil. I was also a radiation oncologist. I practiced at various roles in Pittsburgh, in UPMC in my past life. Now I'm at Allegheny as an academic chief, and I also work for the industry as a VP Medical Affairs for Varian. So I have a dual role. But I have all my life I've done gynae and breast, and gynae brachytherapy and external beam has been my area of interest for a long time. Thank you.
Thank you very much. So I thought what I'd start off with was as just a bit of a warm-up question. As we've got our experts here, we're so lucky to have them. I thought, what does it take to create expertise in gynae contouring? So I was wondering if you guys could tell us a bit about when you sit down to do your contouring, where are you? What do you have in front of you? Do you allocate time? Is it snatched in an evening? And do you have anything like music on, or total silence, or residents asking you questions? What's the setup when you contour? So I don't know, Emma, if you could kick us off.
Wow, that's a great question. No one's ever asked me that before. It's one of my favorite things though about radiation oncology, and there's a lot of great things, obviously. I love contouring. I think it's it's kind of like adult coloring to me. Like, it's so relaxing. It's like a separate mind space. I've heard of people having contouring playlists. That's not me. I've heard of people, doing it at home. I really just like to be in my office. I like pretty much peace and quiet, and I just get laser focused, I think. I do like to make sure I have access to like all the information I possibly can. So that was one of the challenges with this case, not having like a PET scan and an MRI and things like that. Because I think I've come to really rely very heavily on all the information I can possibly get. But no, I just like to kind of get in the zone, I think, a little flow state of contouring.
Great. Thanks. And what about you, C3RO?
What Simon presented was probably the ideal world, but none of us live in the ideal world. So I think like if you are, like for me, the contouring is in between the patients. I've never had, I've never given myself at the end of the day or in the morning. I would just do in between the patient, and I don't have anything exciting around me in terms of music or video or anything else. Just do it as like a job. I love doing it, no doubt about that. But it is fast paced in between the patient rather than on a special day and with a special time and special occasions.
Sure. No, thanks. That's really helpful. And just to focus in on the guiding principles, if you guys could tell us a bit about what guidelines or concepts you use for your contouring for cervix cancer, so for definitive cervix cancer treatment. What protocol would you use?
Yeah. Well, obviously, a lot's changed in the world of gynae cancers and particularly cervix cancer in the last really 10 years. It's been just night and day, honestly. Like the whole time I've been in practice, the world of cervix cancer has been changing rapidly. For normal structures, I still really follow like RTOG contouring guidelines. I still think they're very helpful when you're thinking about the bowel bag, when you're thinking about the sigmoid, the bladder, and the rectum. But really for the target, I mean, I think everybody's looking to the Embrace group. Whether you're using CT or MRI, there's certainly guidelines that can help in either one of those. ABS more so for a CT based, but certainly Embrace for MR based. The nice thing is there's a plethora, and then of course e-contour with some actual cases to look through. I mean, when I was in residency, really none of those resources were around. So sometimes you almost feel like there's too many resources, but intact cervix still remains challenging. Even sitting down to do this case, every case is just so unique. The anatomy is so different. We're actually working as a group in NRG to develop an updated intact for specifically external beam for cervix cancer right now, to focus on some of the nuances that I think are still questions in the world of IMRT and image guided brachy.
Thanks very much, Emma. And C3RO, what about you? What guidelines, stroke atlases do you utilize, or what are your concepts?
Yeah, similar to what Emma said, like for brachytherapy, it's JCastro guidelines. So with some modification based on the practice, and we can talk about it when the time comes. For external beam, I mean, the patient is on the protocol, like we do participate in Embrace 2. So then it's like Embrace 2. But if not, then, Embrace 2 can be very time consuming. It can take a lot of time. And doing on a protocol and doing in day-to-day clinical life could be different. So then it is a combination of what RTOG and Embrace does. So the principle is derived from those concepts, but the exact contouring CTV and PTV may not be exactly how Embrace 2 has defined it. So there is a variation in terms of how we do in practical life and how we do in the protocol. If you ask me honestly, the end result is same. The PTV look very similar, but you reach that PTV from a different perspective, depending on whether the patient is on the protocol or not.
Yeah. Okay, thanks. Yeah, I mean, I share what you say about the time consuming. I'm still at the stage where it takes me about 3 hours plus to do a single case. I don't know, but is there hope for me in the future? Maybe you guys are a bit quicker.
Yeah, I think so. It's like everything. I mean, probably my first 1 to 2 years were the hardest in practice for, just you second guess everything, think everything through, so many different times, come back to things after worrying about it. I do feel like that does get better. I still do take my time with contouring, although I have really great residents, so they do a lot of the contouring, and editing obviously doesn't take quite as long. But sitting down and teaching, certainly can take some time. So yes, it'll get better.
Sure. Cool. So what we're going to do, I think, is we're going to start, we're going to have a look at the case. And if we just remind ourselves of the details for panelists and attendees alike, in case it was a while ago you contoured. So we've got a T3N1 intact cervix cancer here, with involvement of the right parametrium, 67-year-old lady. It's a squamous cell carcinoma, and the involved node was a right common iliac node. On examination, we've got a fairly large tumor, so 6 centimeters, and there's some vaginal involvement, which obviously is difficult to see on the CT. There's a vaginal marker in place though. So the plan is for IMRT 45 grain in 25 fractions as a standard with a SIB to the node. So I thought we'd do is we start with the elective lymph node volume. So here you get a bit of an idea as to how far everyone's gone up. And if we just go to the top of the scan, and then if we sort of pan so we can see the top border, yeah, so we can see there's quite a lot of variation at the top, isn't there? So I don't know if Emma and Sushil want to talk a bit about elective paraortic nodal irradiation and superior borders. We see a lot of variability there, don't we, in contouring exercises?
Yeah, we definitely do. You know, I was torn about that on this case. This lady had a very bulky common iliac node, which is certainly concerning and potentially predicts, obviously, for nodal disease above that. You know, there's some different guidelines that people follow for when to include para-aortic lymph nodes. Some people have a threshold for like number of pelvic lymph nodes or number of common iliac lymph nodes. You know, obviously I don't know this patient and haven't examined her, but I had the feeling that maybe she wasn't like the healthiest of patients. It didn't look like she was really sort of like positioned very flat. She looks quite thin. Many of my patients are also heavy smokers, and I do worry about added toxicity when you contour really high. So I guess I made a few assumptions and contoured just one vertebral body above that bulky node in this lady. But there's certainly more and more data with elective PA nodal radiation conferring a benefit. I think there's going to be some more discussion on that even at Astro coming up.
Yeah, like, so my philosophy is for treating elective parodic node is if common iliac node is involved, or if there are multiple positive nodes. In the past, I used to treat for any positive node. Now, based on the Embrace 1 data, I treat for more than 2 positive nodes. And if I treat parodic node electively, I not necessarily do the same thing which is done in Embrace 2. I go up to the renal vessel. So I do not go by the bony landmark which Embrace 2 has, or going 1 or 2 level up, vertebral level, a centimeter above, like Embrace 2 has, I think, like L3 or something. I go up to the renal vessel. So that's what I did in this case. So I go up to the left renal vessel when I treat parodic prophylactically, and my indication is common iliac node involvement and more than 2 pelvic node involvement.
Okay, thanks. I'm noticing that although this patient has had oral contrast, there's no IV contrast. What do you guys do about that when you're prepping a patient?
I don't usually give them oral or IV contrast. I don't know. Usually I'm using a lot of their diagnostic imaging at the same time. So I'm trying not to overload their kidneys any more than needs be. And I don't know, usually the oral contrast isn't quite so helpful. In this patient, it's really good, but I don't know how long they had her sit and how much they had her drink. Patients usually really hate that experience.
Yeah, I do the same. I don't use IV and oral contrast. In some patient with small, like a lower BMI, where the fat planes are not as well developed, sometimes it's hard to distinguish the bowel loop and vessels and all. In that case, I use a diagnostic CT as a landmark, but I don't give IV and oral contrast. But that being said, there's nothing wrong in giving the IV and oral contrast if your clinic is set up for that. I just try to avoid it for logistics reason and use a diagnostic scan if the need be.
Sure. Okay, cool. And for someone who's starting off doing gynodal contouring, could you perhaps take them through the starter steps of how you create the nodal contour and a few tips and tricks?
So in general, I follow vascular anatomy rather than bony anatomy. So like if I'm treating common iliac, then I go from the bifurcation aorta. If I'm treating the parodic, then I go from the renal vessel. And if I'm treating distal common iliac, which I don't necessarily follow that, even though in Embrace 1 for low risk, they do treat X-ray. Then you go, so follow the vascular anatomy, that's one. And secondly, I follow the same principle, like for pelvic node, give 7 to 10 millimeter margin around the blood vessel, excluding the muscle and the bone. Now, when the bowel loop comes close by, I include one wall of the bowel loop, expecting some motion and all. Some are purists, they exclude completely out of it. I don't completely exclude it out of it. For the parodic node, I go from psoas to psoas because I feel that the risk is more not based on the fixed circumferential margin, but based on the anatomical location. And for the presacral node, I use 1 centimeter in from the presacral, but I don't include the presacral foramina, and I stopped at the level of the piriform sinus, piriform muscle.
Yeah. So you've already mentioned there some areas which I think residents or trainees struggle to modify their contours when they're first starting out. So so common areas where when we've done educational exercises or quality assurance would be the left lateral paraortic space being missed, for example, perhaps not going all the way back to the sacral table, lower down. So yeah, that sort of area. The presacral border, so the width of that, although this patient, obviously the presacral border is slightly complicated by potential mesorectal involvement, so we'll discuss that more a little bit later. And then obviously the inferior extent of the obturator nodes, which can be tricky, identifying that piriformis muscle, like you said, and the levators. So, okay, Emma, can you take us through your sort of how you do it and your tips and tricks for residents when they're starting out?
Yes, I agree. I follow the vessels. I probably like Sushil started with 3D planning and moved to IMRT. And I really try and emphasize to residents that the purpose of IMRT is to decrease toxicity, but not to change where we're covering and what we're controlling as far as disease. So like Sushil mentioned, people, carve out all this extra tissue, all this extra bowel, and sometimes get really, really cute on those lymph node volumes. But, this is a bad cancer. And I really feel that we have to be, generous enough around those lymph nodes, especially treating these huge, long, what we used to call the chimney fields, because, any small rotation in the setup and what you think you're, treating or boosting with an SIB, maybe it's not getting the dose that you think it is. So I think I'm probably a little bit more generous around the vessels. Like I said here, I just did one vertebral body above, but I agree if you're definitely going for the whole chain, I think following the vessels up to the renal vessels is what you should do. It's really controversial to me, the lower extent. Mine's the royal blue, the darker blue on here. And I felt very nervous about the mesorectal space in this lady and many of my patients, which I know we'll probably talk about. There was some mesorectal extension and a lymph node that was very concerning to me. And I always worry about that uterosacral ligament extent too, with those presacral failures even lower down. But I agree with following also the obturator nodes. I think fairly similar, except for I can tell my sup and inf extents are quite different.
So we can see that there's quite a lot of agreement in the pelvic lymph nodes up until that point, and then we see a couple of the panelists. If we just go a few slices more superiorly, Mike, so we can see a couple of the panelists have included the mesorectum in this volume, and then there's one who hasn't included it in this particular volume. So I think probably what we'll do is we'll discuss that when we come on to the primary. Let's just have a look at the node then, the nodal GTV. So Mike, if we just go up a little bit and look at that. So so what do you guys both make of that inter-observer variation?
I think it's like, I think the tissue density was probably too close to the blood vessel. That was one of the factors. And when I was also contouring it, I had to change the background a few times to get what I was thinking was a node. But that being said, I can see, like if you can see some of the area which is included is basically the vessel, the common iliac vessel is included in some of the volume.
Yeah.
And when you track it down, sometimes what helps in this setting is you go up above and below and just track the vessels, and that helps you demarcate the node from the GTV.
Mm-hmm. Yeah, this is where something like a PET scan would be really helpful, or diagnostic imaging with IV contrast, I think. Although you're not going to hurt somebody by boosting, the vessel or the posterior part of the pelvis. So, probably if you are uncertain and for whatever reason you don't have that imaging, it's better to over contour than to under contour. And again, set up variations and things like that. This is quite far away from the bowel, which is your main organ at risk.
Yeah, and I think that's really interesting what you just articulated, Emma, in terms of variation in contouring, because in a lot of the contouring literature, there's mention of a sort of a gold standard, so either a consensus or a staple contour, and then everything that varies against that is somehow erroneous. I think what you articulated is that there's sometimes uncertainty, and then how you deal with that uncertainty depends on your appetite for risk or trading off the risks and the benefits. For example, like your decision, maybe they might not be so healthy. Can they tolerate periodic irradiation? So it's personalized to the patient. So it might be that variation is an acceptable trade-off of risk and benefit, rather than necessarily one thing is wrong and the other is right. I mean, as it happens, this nodal GTV, I think is really quite good agreement. We don't generally see much better agreement in contouring variation studies than this. So apart from in the bladder wall, and even then there's a bit of variation. So yeah, I think there's a fair bit of agreement there. And other modalities would have helped, wouldn't they? So we would definitely have a PET scan fused. The MRI, the diagnostic MRI may not quite go up that far, but if it does, then that would obviously be helpful too.
Yeah, that's the art of medicine, I think, trying to figure out exactly where to start and where to stop. I also added that little GTV down in the perirectal space.
Yes, I thought that looked like a very suspicious lymph node.
That one really concerned me.
Yeah,
and
me too.
She wasn't otherwise very nodey.
Yeah.
Now that you're zoomed in, my contour doesn't look so great, but I was worried about that lymph node.
No, yeah, me too. I contour that in the primary, but yeah, no, I agree. Okay, so let's move on to the primary, and we discussed a bit about. Oh, hang on, sorry, I think we've got a Q&A. Mike's just before we move on from that, we've got a Q&A about the nodal guidelines, and it says there are contour guidelines which suggest the inferior border of the presacral nodes at the level of piriformis, which can go as high as S1, while others contour up to S3 vertebra. Which one do you use?
So as I mentioned before, that in the NRG Atlas, which has just came out year before last, we went by the anatomical landmark and said as soon as you see piriform cell, you can stop it. But in the same issue of Red Journal, there was a prostate atlas which talked about presacral node, and that says go up to S3, and they rather fix somebody else's contour and say go to S3. So there is no consistent messaging within the radiation oncology community. So that explains the uncertainty. That explains why people have different practices. I personally do not go beyond the first visualization piriform muscle, but I can tell you, we are accepting that variation within the two atlas which came out in the Red Journal in the same issue with two separate panel of experts targeting gynecology cancer and prostate cancer.
Yeah.
I think it's a little confusing also because I already mentioned it before, but we moved, just like in many disease sites, from 3D to IMRT, and in 3D planning for cervix, the posterior border on your lateral fields was always behind the sacrum, pretty much all the way down to S3, and then sort of cut over to spare the anus, to include the uterosacral ligament and the whole presacral space. I don't know, it makes me very nervous not to include it. So I think anybody where there's any mesorectal extension or any reason to include it, I would go ahead and contour lower.
Thanks, Emma. Just as a top tip, so my mentor Lee T Tan, who's based here in Cambridge, she actually puts the old 4-field brick on whilst doing the external beam volume, and that can be. I did that as a trainee, and that really helped me, because essentially you've got to have a really good justification for going outside of that volume when you're contouring, and then you've got to understand what are the benefits from going inside, like you said, Emma, about sparing organs at risk, but perhaps
I
not.
love that. Yeah, I love that.
So okay, great, thanks. So if we just zoom down into the pelvis and let's have a look at those CTV primaries, Mike. What do people feel about the right parametrium in the mesorectum here? So if we just go up a little bit, Mike. Yeah, there, stop. Yeah, that's good.
So when I look through that imaging, it's clearly uterosacral ligament is involved, anterior mesorectum is involved on the right side. So the volume on the right side would be different than on the left side. I mean, that's why the way I look at it. You can see the infiltration into the mesorectum, and you can see the infiltration in the uterosacral ligament. So I would take that factor into account when I'm contouring it.
Emma, you were nodding.
Oh, I absolutely agree. It looks so ugly. And obviously CT doesn't tell us the whole story, but in a pre-treated patient, it tells us enough. Post external beam, you might completely be wrong by judging this and really need to use an MRI. But yeah, this is really concerning for even potentially rectal invasion. You can't tell a fat plane there. But certainly mesorectal space invasion, probably uterosacral ligament. It just looks messy, and it makes me concerned for spread of disease there.
Yeah, absolutely. So I just contour with the Embrace 2 guidelines. That's what I'm used to, and that's our volume concept. But in the RTOG guidance, which I'm familiar with in one way, but don't actually use clinically, they would suggest that you incorporate the whole mesorectum into the primary CTV, which then you get a 1.5 centimeter margin to me. So to me, I was struggling with that. Add a 1.5 centimeter margin. I wanted to just draw around the whole mesorectum and add a little margin to that. So I don't know how you guys dealt with that, and whether you've sort of, like you say, you transitioned slightly from the RTOG guidance.
Yeah. So when I mentioned that, when we wrote the RTOG Atlas, that was more than 10 years ago, and we were in the era of 2D versus 3D. A lot of people were still in the 2D era when we wrote that Atlas. So in the room when we were there, some people were like adamant about including the mesorectum in the CTV for the stage 3 disease. Others were not. I was on the other side, just to let you know my perspective. So when we were coming out with the consensus, we have to respect everybody's opinion. And since that was the beginning of starting of contouring Atlas for cervical cancer, we say we should include mesorectum for stage 3B disease. But in practice, I never did that. And other people are also not routinely doing it. And none of us have reported isolated mesorectal recurrence. So that being said, that was reflected in the RTOG Atlas. But when I said I use a combination of RTOG and Embrace, that's where one of the differences is. I do not include mesorectum in my volume unless mesorectum is involved or there is a PET avid node in the mesorectum.
Yeah, I think I'm on the other side of that. For this, I wasn't sure exactly which volume to include it in. So I think I extended my primary a little bit and then also had some of it in my elective nodal. But I think that's why there's really a need to update some of the contouring atlases, especially for these more advanced disease, especially now we're using MR and finding this mesorectal invasion, involvement, more small lymph nodes, to really get a consensus of how to manage these women better.
So what I would say to the residents on the call is that don't feel too bad if you didn't contour any of the mesorectum. This is I'd say this is definitely at least moderately, if not significantly challenging in this case. It's not one of your absolute standard ones. So but in a way that makes it, this is real life. This is what happens when you hit clinical practice, isn't it? Okay. So we've had a look at the mesorectum and that extensive disease. Should we talk a little bit about the parametrial border? It's another area that residents tend to worry about. Do you think unnecessarily or necessarily?
I think because it's not a well-defined anatomical structure. And again, there is some differences, even though the Embrace and RTOG have some consensus for the parametrial contouring. The Japanese contouring guideline is a bit less generous for parametric contouring. So I always said, I mean, it's a space. You have to contour the space. It's a space much better visualized on MR than on the CT. But when you do it, you can get used to it. And I follow the standard landmark. Like medially, it's a cervical border, and laterally, it's the obturator internus. Anteriorly, it's a bladder. Posteriorly, it's the rectum. And superiorly is the adnexa, and inferiorly, it's the urogenital diaphragm. In the Japanese contouring guideline, they don't go up to the adnexa for the parametrium. They stop at the level of the upper border of cervix. So there is some difference. But I do make some judgment call based on the case. But those are the guidelines I follow, like in terms of defining superior, inferior, anterior, posterior, and lateral medial border.
Yeah, so this is a classic, lots of variation in the parametrial extent we can see.
Variation which comes up is adnexa. Sometimes adnexa is bigger and larger. You don't know how much to include, not whether to include or not. It's locally advanced cervical cancer. There's not much data on adnexa involvement. So as if the adnexa is larger, like in this case, I felt that was one of the factors, especially on one side, that you are debating whether to include or not. But otherwise, you can see like laterally obturator internus, anteriorly bladder, posterior rectum, and then as we go inferiorly, we'll see we stop at the urogenital diaphragm. Now, some people stop at the like if you look at the embrace 2, they'll stop at the medial edge of the vessel for the lateral border, and that's what some people have done it. But in either case, I don't think makes a difference, because when you're treating a pelvic node, you always go up to the obturator internus. So how you reach that, that's what I was talking about, Simon, whether you follow embrace 2 and be picky about it, or you do something practical to reach the same results.
Yep. Sometimes it's a little bit dispiriting when you spend 4 hours delineating every little sub-volume, and then you end up with essentially a full-field Brit type, scooped with the middle scooped out. Yeah. Okay. Thanks. Yeah. And Emma, any tips on the parametrium?
No, I mean, I think it's tricky. I think using a combination of your exam and MR can be really helpful. This is where really making sure that you get to examine the patient is helpful. And even filling out a diagram when you examine them, or making sure you write a really thorough exam so you can be sure to cover that in your treatment, and then also monitor it as they progress through treatment. Yeah, I think there's lots of different ways to do these things, obviously, and lots of different naming conventions. So, people can include them in different structures. But I think you're right. Sort of by the time you do your contours, by the time you put on your margins, oftentimes everything ends up to be about the same. What I typically do is do the entire uterus and cervix. And then I add a really quite a generous margin because I worry a lot about the movement there in the pelvis with IMRT. So probably it ends up being quite similar to some of those more generous contours to start with.
Sure, thanks.
And one other variation I'm noticing here is the amount of vagina included.
Yeah, we're just going to move on to that. We've got a question from the floor as well. Yeah, let's have a look at we can see on the sagittal quite nicely. Mike, if you just zoom a little bit more into the sagittal view and then pan it up so we can see that bottom border nicely. Oh, we can see the vaginal marker as well, that black rod coming in. So this is an area where we see lots of variation in contouring exercises. And what we've had a question from the floor. So in patients with gross tumour, the local CTV or the primary CTV usually extends 2 centimeters below the most inferior extent of vaginal disease. However, in patients with MRI guidance, can we reduce the expansion to 1 to 1.5 centimeters to decrease potential toxicities such as vaginal stenosis? That's the question. So with a view to these contours, what are your views on that, Sushil and Emma?
To some extent, that's where Emma's point comes up, how it looks on the exam. Normally what happens is that I would include upper 2 to 3 centimeters of vagina in my CTV. The guidelines accept up to 2 centimeters. But when I see significant vaginal involvement in the upper part, then because of communicating lymphatics and all, I end up treating almost a significant part of the vagina in my 45 gray volume. So I'm a bit more generous in involving the lower part of the vagina if I see significant upper part of the vaginal involvement, just because of communicating lymphatics and all. So I don't follow the 2 centimeter cutoff if there is significant vaginal involvement. I do use 2 to 3 centimeter cutoff if vagina is not involved. But in case of involvement, I tend to be a bit more generous because of communicative lymphatics and the concern about microscopic disease in the vagina.
Yeah, I rely on the exam too, and I actually usually place fiducial markers when I examine these ladies in clinic, try and mark the lowest extent of disease, because I find that can really help on your CT scan. And then I don't usually use a vaginal marker. I don't know how people feel about that. I guess it's kind of like ingrained into my head that if you do something at SIM, you have to do it for every treatment, even though I know they're very, very small. And I can't imagine having to put one in every day. So that's not part of my practice. Another trick, and you already mentioned it, that Lee T does, but is put on your standard 4-field border and mark the bottom of the obturator foramen. And that can be a really good sort of sounding board. So if your contour is way higher than that on your 3D rendering, it can kind of guide you where you need to be, because the cervix and the vagina are actually really, really hard to see on CT scans.
Yeah, and I think that's an interesting point about the question. When even a really lovely quality MR, often you do a clinical examination and find something quite different to what you saw on the MR. So that's the first thing. MRI doesn't give you everything. I think the second thing is that you've got to be really careful, even when you can see the disease. There's quite a lot of inter-observer variation in the inferior border, and it doesn't take much to erode your 1 to 1.5 centimeter margin if it's quite tight. I remember that if you're doing something like volumetric art therapy, the dose gradient at the inferior edge is really quite sharp. So if you miss anteriorly for the uterus, then that's going to get some dose, because the fact is the dose fall off is not amazing. You know, there is some dose. Whereas inferiorly, it doesn't take, you don't have to go very far to get down to to go out of field. And so if you miss out of field inferiorly, that can be a problem. So I think until you're really confident with that inferior border, better to go bigger rather than smaller. And that goes back to Emma's principle of make sure you don't miss as your first principle in this sort of curable radiation sensitive disease.
Yeah, and I don't think that the external beam is the main driver of the vaginal stenosis for cervix patients. Unfortunately, they get such a high dose with vaginal brachytherapy. So yeah, just agreeing with your point.
And one more thing I want to highlight, like when we contour it, like for example, I try to respect the anatomy. So I try to not include the muscle, not include the urethra. It may sound that it is small number. When you do expansion, then it becomes, the 3D expansion becomes larger. So like, for example, when I'm going to the lower half of the vagina, make sure urethra is out of it and the perineal muscle is out of it. So that way you're treating less volume with 3D expansion and all.
Great, thank you. Any other points that you guys wanted to make about that primary volume?
I mean, I think it reflects the practice pattern of what is your comfort level. It looks like I was in the middle ground and Dr. Fields was in the lower ground, just based on the principle you follow. So that reflects on how much, how you assess the risk. And so that's where the clinical judgment comes in, and that's where the exam comes in. And imaging is only part of it, but there are other factors which come into play for sure.
Yeah, and always difficult on these simulated exercises where, like Emma said, you haven't examined the patient, you haven't felt it, and you don't also have that multi-modality imaging.
And one more thing I want to highlight, that when we talk about the GTV node, so most of us, when we do GTV node and we give some expansion for PTV for SIB, but in the Embrace 2 protocol, they allow 0 to 2 millimeter margin on the GTV node also. So that's another variation in practice. I don't give any CTV margin on the node for the GTV and just add PTV and do the SIB. But so like in practice, some people give some margin just for accounting for that. Margin may be accounting for uncertainty of counting, which you talked about, Simon, or it may be accounting for, but before you start treatment, there may be some delay and there may be some growth happening. So, there are various ways to tackle the same problem. I'm just emphasizing the fact that there is no right or wrong answer. You just need to know your principle of why you're doing and what you're doing.
Thanks, very good. Okay, so if we just have just before we move on.
Yeah, we have some questions.
Okay, you go, Diana.
We have a question: in the setting where MRI is not readily available, do you think insertion of a fiducial marker or intravaginal swab is good for an alternative? If so, how do you apply it?
So we Emma was saying she does put a fiducial marker in. We use a vaginal marker sometimes, and I have to say I've very rarely found it useful because it moves, and like Emma says, it's something that's in there that is never there in the rest of the treatment. So I'm interested in Emma's fiducial marker technique. Maybe we should get into that.
Yeah, it's amazing how well it's tolerated. And then you can always add more markers at brachytherapy too to guide that.
So is that a gold seed or?
Yeah, it's a gold seed. Yeah.
The similar ones that you'd use for prostate.
Yes.
Okay.
Yeah, absolutely.
And then was there another one?
Yes.
Oh, I think it's about using an ITV.
Mm-hmm.
I do. I love to do bladder full and bladder empty. I think it's a good practice for women too, to come and see what it feels like with a full bladder. I prefer to treat them that way. But to then practice emptying their bladder, and then I can show them the difference and how it can protect their bowels, kind of make them invested in it a little bit as well. And it reassures me when I'm adding that margin onto the uterus as well.
So, I do it both ways because there are some practical limitations. Sometimes we do PET-CT sim, so the empty bladder may not be there. In the ideal world, we try to create an ITV, but if I don't create an ITV, then I give population-based margin, which are larger to account for the ITV. So I have done it both ways. I mean, ITV, if we can do it, we do ITV. If not, then contour the CTV and create a larger margin when you do the PT, which incorporates ITV as well as set of margin.
Yeah, so we use an ITV concept. What we do, we're really restricted to our CT's time. So what we do is we use CT sim with a full bladder, and then we use the empty bladder for the diagnostic MRI and also the PET. The point I'd make to residents is that the target is most affected by rectal filling, which obviously you can't necessarily systematically alter. And so you just have to be really careful. If you've got a very empty rectum, that the target could well move significantly anteriorly if there's a lot of gas there that comes. And likewise, if you've got quite a full rectum, obviously you'll have protocols. You may say, rectal diameter maximum 4 centimeters, or you have to rescan, but just be careful of a big rectum that if you have an ITV concept, that you're coming far enough posteriorly and that there's not a risk of geographical miss if they pass wind. Yeah. Should we just have a quick look at the bowel bag as a final look?
And as you bring the bowel bag, I just want to emphasize, like, if you did not do ITV and did population-based margin, you did do daily cone beam CT, and you see the variation, then we sometimes replan based on that what we see on the cone beam CT. So just be ready for making the changes, because population-based margin works 90 to 95% of the time, but in each individual patient is a patient. So you have to be ready with the fact that it may or may not match.
Yes, I was interested to do this because we don't use oral contrast at all. I think, Emma, you were saying you don't either.
No, we don't either. I think my question on this was, normally when we're treating up higher, I'll kind of delineate the upper abdominal structures a little bit different. And I wasn't sure what we were looking for with this case. I probably would have contoured out the stomach and the duodenum separately. But for the purposes of this, I did put them in all together.
Sure.
Yeah, I agree. Like I felt the same. Now the main difference is like whether to contour the entire cavity or not. Usually I tend to go from bowel edges to bowel edges, but some people do the entire bowel bag. And the denominator changes. I don't know whether it makes any meaningful difference or not. So I think it looks to me that most of us are very consistent in terms of what we did.
Yeah, no, I agree. I mean, as it happens, the bowel's packed in there, isn't it? So if someone was drawing bowel loops, it might look a bit different, but pretty much the whole peritoneal cavity is full of those bowel bags, isn't it? So yeah, I'd say that's they all look very similar to each other, don't they?
Yeah.
And to be honest, I had a look before, and most of the difference, there's some interpolation related differences between the contours as well, I think. I don't know if either of you had any final tips for residents who might be interested in gynae and thinking about taking their skills further with this exercise. any tips for them for the future, both in contouring and in terms of gynae cancers, you know, being a gynae specialist in general?
I just want to emphasize that the so-called experts do not have consensus, so don't worry about that. Just I always say follow the principle and concept, and when you contour it, identify the anatomy, follow the anatomy. Then you're less likely to make an error. If you do not know what structure you are contouring, take the help of radiologists. I mean, all of us have learned through the process. If I look at my contouring 15 years ago, I feel bad about it. So that being said, all of us have evolved over a period of time. So always identify the anatomy. Do not contour anything which you do not identify, and follow a principle. And if you follow the principle, then you are consistent in your approach. And you know that principle may or may not be consistent with what Emma does and what I do or what Simon do. And that being said, it is accepted variation as we are discussing in the group.
Thanks very much, Sisha.
Yeah, I think treating gynecologic cancers, especially cervix cancer, is one of the most rewarding cancers to treat because we get to see it shrink away as we treat. It's just incredible. I mean, as these ladies are going through treatment, I'm sure all the residents who've ever been on service, you know, you hear very quickly, they stop bleeding, they stop discharging, they start to feel better, the pelvic pressure goes down. Of course, then we cause a lot of bowel toxicity. But, you know, it's really an art getting these ladies through treatment and knowing that you put careful consideration into their plan and that you've done it thinking about how best to cure them, how best to minimize toxicity. And seeing great results. It really is the best. And then adding brachytherapy onto that, you know, this is really where the true art of medicine, I think, comes in because, you know, like Sushil said, we don't have true consensus, but we're all taking really good care of these ladies. And yeah, I think, you know, we're making a big difference. Hopefully at some point we won't even see ladies with cervix cancer, but and until that happens, you know, making sure that we're doing a good job and continuing to improve both outcomes and decreasing toxicity is going to be really important.
Thank you so much, both of you. That's really insightful and I think quite inspiring end. Dan, did you have anything? I think there were some things that you wanted to go through. Is that right?
Oh yeah, well, we're just gonna announce the Amazon gift card winner. So that's the fun part. So we're just gonna draw 2 folks for who contoured and then 1 person who attended live today. So congratulations to Marina Sokolska and Jacqueline Makoka. Sorry if I'm butchering your names. And then for our live guests, it's Vandrom Nakundi. So congratulations. We'll be sending out these gift cards in a few business days to the email that you registered with. And in closing, we'd just like to thank all the panelists for having such a great discussion today, and to all the attendees who kind of contoured and were part of this. So thank you so much.
Thanks everyone for being part of it.
Yeah, thanks for hosting.
Thank you. And Emma, if you don't mind asking, what was the timing at Boston?
Oh, I did 3:36 and I requalified for next
Wow.
year.
we all feel so like what was the qualifying time for the Boston Marathon?
3:40.
Oh, wow, they're proud
Or
of you.
I had to be under 3:40. I think I did 3:35 to qualify. So
Wow.
thank you. Thanks for holding off a week for me.
You are the second person I know in my life who qualified for the Boston Marathon. Okay, thank you.
That's cool. Thank you. Thanks, everybody. Have a lovely evening.